Okay. We'll just start with some really great news. So breast cancer and physical therapy. I just wanted to point out that the average 10-year survival rate for women with invasive breast cancer is 84%. Even better news if it's only in one breast. The 5-year for those women is 99%, and 62% of women with breast cancer are diagnosed with this stage. So, and I got that from cancer.net. So I just want to start by saying that breast cancer is no longer a death sentence. Like it's much more, becoming much more like a chronic condition that needs to be managed. However, which I think you'll see from this presentation, I don't think our healthcare system has caught up to that reality and kind of leaves women kind of hanging in the wind a little bit. Oops, sorry, wrong button. Okay, so breast cancer treatment can leave women with a multitude of issues, and that can be by treatment, I can mean surgery, chemotherapy, adjunct therapies, radiation, any of those. But physical therapists, we're the experts in helping people kind of get back to your best self. And to use another example, imagine a patient had a stroke. So a stroke is when a blood clot travels up to your brain. So patient goes to the hospital, and if it was treated the way breast cancer is treated, they would say, all right, we removed your clot. Our work here is done. Go back into your life. But if you've known anyone who's had a stroke, you know how terrible, what terrible medicine that would be. You know, they might have half of their body might be paralyzed. They might not be able to speak, have walk, or even have some cognitive issues. But as we know, that's not what actually happens. And we have a really great medical system set up to deal with strokes. So instead, what happens, someone goes to the hospital, they deal medically with the actual stroke, but then they bring all of these different therapies to help. We have speech therapy, we have the nursing, physical therapy, occupational therapy. And then once a patient's discharged home, it's not like, all right, good luck. It's like, okay, let's see, do you need a therapist to come to the house? Do you need maybe a ramp instead of stairs? What kind of support can we give you and your family? Let's get that all set up. Unfortunately, we do not have, that same standard protocol in breast cancer. Right now, it's a little bit more like, hooray, your cancer's gone, you're back to normal. And what can even, unlike a stroke patient where you might physically see that someone has changed, a lot of times with breast cancer, 1-2 years out, you look normal, like you look healthy, people around you think you're healthy, and it can almost feel like an additional, I don't know, burden's the right word, but like not only do you not feel great, but you also have to deal with people expecting you to act like you did before, you know, to not be tired, to be able to do whatever. So some common side effects of breast cancer treatment that we'll talk about today, there might be shoulder issues after surgery. Scars can be a big issue. Fatigue can definitely be an issue. Even pelvic floor, and I mentioned this one in particular because I think this one super gets left out of a lot of conversations. And then lymphedema. Okay. So for this slide, I mentioned surgery, and I kind of mean that general in this. We'll get into more specific surgeries, but in general, if you have surgery, so lymph nodes removed or a lumpectomy or even a mastectomy, things that we can do as physical therapists are help you get you back feeling better. So that includes stretching your shoulder. Where we stretch it, we teach you how to stretch it. We might do massage, particularly when I've seen women immediately after surgery, like they just had a lumpectomy, they just had a mastectomy, they were cleared to leave the house, like, oh my goodness, all their neck muscles and things that aren't even directly related to this surgery can be very tight and sore, and just coming into the clinic, we can ease that for them, help them feel a little bit better with less medication. We'll do special massages to relax those muscles, do different exercises, ones that we can teach you to do at home, and then also ones that you can do in the clinic with us. And then scar management. In this scar management, I think the general public, we kind of think, oh, scars, right. I don't want people to see my scars. That's kind of where our thought ends with them. Like, how do I make them look prettier? And that's certainly something we can help with. As an aside, I went in a deep dive of scar tapes recently, and if you have scars that you want to fade or to look better, the secret ingredient is silicone. So you'll see there's tons of different products on the market, but silicone is the one that actually will make a difference in fading it. Aside from just the appearance of scars, though, from a PT point of view, we are worried that maybe those scars are getting in the way of how you move your arm. They could be limiting how your lymph system is flowing. So we do different things to help soften them. There's also some people who, typically scars are sensitive initially. As time goes on, they feel better. There's some people that need help in that phase from my scar is really sensitive to, I don't even think about it anymore. And PTs can help with that desensitization. We can help it so you can touch it or put a bra on over it, or have your kid hug you and it doesn't hurt. So those are all different sorts of things. And we do that with, we actually have lasers that sound more exciting than they are, but there's lasers that can help with this. There's special tape, if any of you have heard of kinesio tape, that can sometimes help with softening scars. We have special massages and things that we can do as well. Also, if I start, I'm an East Coaster originally. If I sometimes start talking really fast, just someone wave me down, slow me down. I'm trying to rein it in. I get excited and I talk even faster. Okay, so here is a special one for axillary lymph node surgery, cording. So this is a really great picture. You can see in her armpit. If you're not a physical therapist, you might think, oh my gosh, this tendon hurts, because it kind of looks like a tendon. But if you've studied all the anatomy for all the years like we've done, we know there actually isn't a shoulder tendon here. That's a result of your lymph node surgery. Cording is harmless. It's not, it has nothing, it doesn't reflect at all upon the prognosis of your cancer or lymphedema. No relation to either of those, but they can be painful, and they can sometimes even limit your arm motion. Typically, the way people describe them, it's different than like, I'm kind of tight here, or my calf is tight. I don't know if we've ever gotten like a tight calf muscle. If you stretch it, it pretty quickly feels like that's what I needed. But with cording, it's a real specific pulling where you can almost trace it with a finger and say, yeah, it's right here that I feel it. And if you go to stretch it, it doesn't feel nice. It feels like icky. It might feel burny or even tingly, or as a PT, we think of it more like nerve pain, but like it's like ugh, kind of a feeling. It can, often it's in here, it can travel all the way to your elbow. I've met some women where initially I see them and they can't straighten their arm all the way. It can also go into the palm of your hand, where you can feel it, where you're like, if you're reaching back like this or reaching in certain positions. I very scientifically called it here in the third bullet, weird scar tissue. The truth is, we don't 100% know what and why this happens. Some thoughts are, there's a couple different types. This woman here, it might be like kind of a scar tissue from, you can actually see her little incision right there if you look at my cursor. This might just be a thick cording that happened, like scar tissue. So if you imagine, like if I show you my jacket here, if I make a stitch here, like things are gonna pull. So that could be what hers is. Sometimes cording is less distinct, like this is a really nice distinct line, and sometimes it's a little bit more webby. The webby one, the thought is that the lymphatic system is becoming tethered to the stuff around it. Again, we don't know why that is. And then it can also follow the pathways of the veins in the arteries. So it could be like the vein coating gets all inflamed and then gets connected to the stuff around it. We don't really know. Some risk factors, though, if we're going to predict who's going to have it. If after your surgery you end up with the seroma, there's more of a chance you'll have it. Being thin and lanky, like just kind of like long-limbed people tend to have it more. And it is not, like I said earlier, it's not a risk factor for lymphedema. Having cording is in no way, has nothing to do with lymphedema or the prognosis of your cancer. And then the way we treat it is gentle stretching. There's special massage techniques. And typically I tell women, if you feel it, do your best to work through it. Sometimes it's just too painful and you can't, but you won't make things worse. So if straightening my elbow, I'm like, oh God, that cording, it feels like something's going to tear. It's okay. Like, go ahead, and it might tear, and that's fine. And then you'll, women will sometimes respond hearing a snap or feeling like a ping, like a rubber band snapping, and then suddenly know, oh, check it out. I can move and it doesn't hurt. That might happen. It's not necessarily our goal to get rid of all of the cording, like the visual aspect of them. For example, if this woman in the picture, if she's able to move her arm around, and although we can see the cord, it never bothers her, we will just let it be. Because again, we don't 100% know what it is. So if it's not bothering, we just kind of leave it alone. Okay. So mastectomy. So this slide is just kind of mastectomy in general. We'll talk about reconstruction in a moment. So we can help, actually, I'm having a light bulb moment at this moment. I should have put in the slide, it's great if we can even see you before the surgery. One way we can really help is prepare you by kind of like teaching you how to get in and out of bed, giving you tips like you might want extra pillows or a recliner, or, kind of talking about all of those things. But let's assume you had that and now you've had your surgery and you're coming to see us, and we'll help you increase the range of motion of your shoulders. Again, we'll talk about softening the scars. We can improve your posture because, first of all, probably everyone in the US needs their posture improved, but having surgery to your chest, it's just a natural kind of protective thing to sort of fold forward, so we can help with that. Like I mentioned earlier, a lot of times there's neck and upper back pain initially after surgery. We can make that feel nicer for you. And then we can identify and treat lymphedema in the trunk or in the arm, but we'll get more to lymphedema. Has this whole section at the end, so we'll get more into that later. Okay, so reconstruction. I'm going to talk about two main types that we see a lot in the Los Angeles area. Part of reconstruction and what a woman chooses, part of it is what she chooses, but there's also all of these factors beyond her control, such as what did the doctors in my area do? What does my insurance pay for? Did I have radiation? If I had radiation, that can make a change. So I'll explain these, but these are the ones we see most often. The breast implant, and then the, I believe it's autologous, or the flap. And flaps are when you use parts of your own body to create a breast, where the breast implant uses like a saline implant or a silicone implant, almost like a prosthetic that they attach to your body, where the flaps use your own parts of your body. There are also butt flaps, like they can use muscles from your glutes and thighs too, but I honestly haven't seen any of those in the LA area, so I don't think they're super common around here. Okay, so let's talk about breast implants first. The implants themselves can live either above the chest or underneath it, and when I say the pectoralis, that's the muscle. If you look at like a beefy guy, like those are like the chest muscles. So some women are good candidates where you can put it just right above the muscle under the skin. Most women I see in the clinic have the implant underneath the pec. So the expanders, they're usually used, they're like phase one of the mastectomy reconstruction. So you have your mastectomy, they remove the breasts, and then they will put an expander. And what the expander does is it creates a pocket for the implant. So it kind of like, you know, because our bodies don't come with like extra pockets for implants and things. So it allows time for the tissue to stretch and create the shape to later hold the implant. And what typically happens is after surgery, women will wake up and they have these temporary expanders in. They're breast shaped, and then every so often they'll see their plastic surgeon, and the plastic surgeon will expand or fill up the implant, excuse me, the expander. So it starts off kind of small, and over time it gets a little bit bigger, making and stretching out that pocket. So we'll see women, and it's a little, initially during this expansion phase, it's a little bit like 2 steps forward, 1 step back, where you come in, your motion's starting to feel better, and then you get another fill or expansion, and you lose some of it. So we help women through that phase with stretching and massage. And in general, just trying to make this phase easier. So we'll stretch the muscles, we'll again work on shoulder motion, and just try to decrease the pain. Okay, so now to talk about the flaps. And sometimes flaps are the only option if you had radiation. Radiated skin can be tricky to work with. So if you have radiated skin and then they have to do an incision over it, it doesn't always heal the same way non-radiated skin does. So if you have radiation damage, flaps are an option. There's 2 types of abdominal or tummy flaps. The first one is the tram flap. That one is a little bit, that's like the old technology, and that uses part of your abdominal muscles, where they would kind of, I don't know how, but they would like remove some of the muscle and then sort of flip it up and shape it into a breast. Now more common, and I'm seeing many more of these in the clinic, is the DIEP or deep flap. It stands for deep something or other, something. Sorry, I should have not even tried to say what it just, it spells it's the acronym of the blood supply, the artery, the deep something epigastric, some perforated.
Inferior epigastric.
Thank you. Thank you from the peanut gallery. Yes. And it refers to that inferior epigastric perforating artery, and they're able to keep that intact as they flip up the tissue and create that. Sometimes flaps do use, the deep flap does use an actual implant in addition to the skin. Usually it's just the actual, your own tissue. There's no other implant used. Special considerations are that it's a bigger and longer surgery, and your abdomen needs to recover, not just your chest. So if anyone's had a C-section, it could be a little bit like that, where you don't notice how much you use your abs in every single moment of the day until you're recovering. And you're like, ooh. Similar if you've had a really, kind of similar, but similar if you had a really tough ab workout and the next day you're like, oh my God, I can't even sit up. It's sort of like that. But the scar, you'll also have more scars. So you'll have there's a long scar kind of like right above your pubic bone that kind of goes horizontally. It's bigger than a C-section scar. And then you'll have the scars in the breast as well. So so physical therapy is definitely helpful for those, just to help, even like as silly as it might sound, but to help soften your abdomen, because you kind of get a tummy tuck. Like women who have the surgery then now have a really flat, lovely, everything is really tight, but sometimes that tightness can feel a little funny. And I haven't read any like long-term research or study on this. They might exist, I just haven't seen them. But sometimes when you really let's see, if you are making this tight, so increasing the tightness in your abdomen, that your abdomen is like the front wall of your whole body cavity. So if there's a lot of tension in there, it makes sense to me that like if you're someone who is prone to heartburn or like GERD, you know, any of those sort of things, acid reflux, if there's all this tightness in here, it's just, it can push things up. That's not, doesn't have to be permanent. And again, we can work with you to loosen up the tummy. But I've met several women who tell me that like, yeah, I never really had heartburn until I had the surgery. And then the other thing could happen is, again, that same idea, if you're really having a lot of pressure in here, instead of pressing like the acid reflux up, if it presses, so, you know, it presses down, it's kind of sort of going down, that could trigger, in theory, like any like incontinence or a little bit of leaking here and there. That is theoretical. I haven't actually met anyone where that's been a problem. So just for something to think about. But most people I'm seeing are super, super happy with these procedures. Okay, so then the latissimus dorsi flap, that's using one of your shoulder muscles and flipping that over. In the Los Angeles area, I'm seeing much more of the deep flaps and even the lat flaps. Like that also feels a little bit like older technology. Although we still do see some, but that uses your shoulder muscle to create the breast. And special considerations for rehabbing that is the potential weakness in your shoulder. It's a little bit of a robbing Peter to pay Paul scenario where you're taking some muscle that, you know, had a job in life, and now its new job is to be a breast. A lot of surgeons like will say, one patient told me her surgeon said, well, you're not a professional volleyball player, so no worries. And that's probably true. Like if you're not someone who's a competitive tennis player, it's probably not going to be a big deal, but it's something to think about. And there are more scars, like there's a big scar like kind of on the back of your trunk. So yeah, all right, so that's that. And moving on, I'm going to talk about radiation. So what can PTs help with for radiation? The first thing that we do is we help get you ready for radiation. So this usually happens, you finish chemo, the like kind of the typical treatment plan is you do chemo first and then maybe surgeries, and then after surgery is time for radiation. So if you've just come out of surgery and you had lymph nodes removed, whether it's a lumpectomy or a mastectomy, there's a little bit of time where you don't want to move your shoulder. The radiation position that you have to be in for treatment is something like this. Like it's different for everyone depending on your body shape, just exactly where your tumor was, etc. But it's something kind of like that. So typically, we see patients where it's a situation like we really want to start radiation ASAP. I need help getting my shoulder moving. So that's something we are great at. And then we do help women even during radiation. So radiation can sometimes temporarily tighten up the shoulder again. So for women who were like, yeah, I'm doing great, and then 4 weeks or so into radiation is starting to get a little bit tight. So we can help with that. But I do want to mention the top priority during radiation is just to keep your skin happy. Your skin will be going through a lot of trauma. It needs love, it needs moisture, it needs to be protected, even if that means your shoulder gets a little bit tight for a little while. So sometimes we have to sacrifice shoulder motion in the temporary just to keep your skin happy, and that's totally fine. Like we can get the shoulder moving again once your skin has healed and radiation is over. After radiation, if you lost any shoulder motion, we can help with that. We can also help break up any radiation fibrosis. And fibrosis is kind of a fancy word we use. It's almost like scar tissue, or just kind of like it'll feel hard. It can be particularly noticeable if you had a lumpectomy and then you had radiation to your breast, where maybe around the incision, like there can just feel like hard tissue, and it can be scary. It can even feel like a lump has recurred, but oftentimes that's just the fibrosis, just the changing of the tissue from radiation, and we can soften that up and make that feel better. Okay. All right, so fatigue. Now you'll notice on this slide, I put the American Cancer Society because I thought it was pretty cool how they explained it. So I'm giving them props here, but let's talk about what weakness is versus fatigue. So weakness is when you have decreased strength in muscles, making it hard to use them. So if you had, you broke your arm and it was in a cast, when it comes out, you're gonna have weakness in your arm. That doesn't necessarily mean you generally have fatigue. Where fatigue, that's an extreme feeling of tiredness, lack of energy, despite getting enough sleep. And there are so many reasons that after breast cancer treatment, you can feel this. Part of it could be general body weakness, where it's more tiring to go up the stairs because you were ill from chemo for a while and you weren't moving around as much. So your legs are actually weak. So the weakness can contribute to that. Okay, and how can PTs help with weakness? So one of my pet peeves in the world is the idea, like, exercise is hard. I just want, like, the fact that that's not recognized, that's my pet peeve. Exercise is hard. And what I mean by that is, like, I've heard so many, like from my family members or patients, where the doctor says, oh, you just need to exercise. Okay, great. Like, I mean, if I could, I probably would be. If the doctor's telling me there's probably a special reason, so maybe I'm overweight, maybe I have joint pain somewhere, like, so these are all things that could use help. I also, since COVID times, I've been doing we got a Peloton. So I've been using the Peloton, doing exercise classes there. And I think to myself, like, who do these instructors think we are? Like, the things that they are doing that are supposedly, intermediate or beginner, that are just nuts. So yes, so that's my little soapbox, that, like, just going out and trying to follow a video, like, yeah, you probably hurt your neck. I mean, like, there's a chance you might strain your neck, and I don't mean that as, like, don't do it, but if you are trying these things and you're finding that they're not working for you, yeah, I don't know who they're working for, except the 20-year-olds or the fitness instructors. But that's my soapbox. And I say that because PTs, like, this is our wheelhouse. Like, come to us, we can help you figure out what exercise is appropriate for you. Or even, like, if say you like doing Peloton, we can help you figure out, okay, you want to ride your bike? Here are some special considerations that Cody on the bike isn't going to mention to you during his class, but I'll mention to you, and then you'll know them and you'll take them to class. So we're so good at this. Like, I just wish that was more known in the general public. And so then by increasing your strength, we'll get rid of the weakness. So it might not be feel like as such an effort to have to walk up the stairs if, say, your legs are weaker. But then we'll go through, there's so many other exercise benefits. It kind of feels like exercise is the golden bullet, like, it's just kind of like, it seems to fix everything. But here we go. Let's list some of them. It'll increase your endurance. So that means, like, right now I get tired going to my mailbox. If to work on increasing your endurance, you won't be tired going to your mailbox. In fact, you'll be able to walk all around your block and not feel just exhausted and drained. It can work on building bones. And for women who have estrogen positive cancer, osteoporosis or bone loss, like that can be a side effect. Which I actually should have put in this slide. I apologize. Another lightning bolt moment for myself. But yeah, so we can work on teaching you the right type of exercises to increase your bone mass, because they're not all exercises created equally when it comes to osteoporosis or osteopenia, which is the phase before osteoporosis. So weight-bearing exercises, things like different standing or having weights, or doing, like, walking around the block with an exercise, like a weighted vest. Those are helpful, where swimming is not so great for building your bones. Can work on your balance. And if you have chemoneuropathy, particularly in your feet, that can affect your balance. So we can't necessarily get rid of the neuropathy sensations, like the numbness or the tingling, but we can help you overcome that getting in the way of your balance. So obviously it can be good for weight loss, decreased risk for lymphedema. We will talk more about that, but weight loss, or excuse me, a healthy BMI is a is good for minimizing your risk for lymphedema. I want to make sure I'm saying that right. So if your BMI is higher than it should be, that increases your risk for lymphedema. The other issue with exercise and lymphedema is strengthening, particularly like the muscles, strength training the muscles in your arms. That helps pump lymph. So some women who have lymphedema actually manage it through exercise. Yeah, and then it improves your mood, improves your sleep, it improves digestion. You know, if you're someone who gets constipated or bloated, it can help with that. Yeah, it's kind of amazing. But so get ready for my shameless self-promotion. We are doing Sit and Fit, this class every Tuesday. It's free, it's at noon. If you are interested, you can drop it in, like, actually the same email you used to sign up for this class. That's Sabrina. She was my co-host of this meeting. Just let her know. She'll send you the free link for it, but it's every Tuesday at noon, and it's a class designed, it's great if you don't know where to begin, or if you feel like I'm so out of shape, I'm not appropriate for Peloton or for any old yoga class or 5-minute ab videos or whatever. If you're not, you know, we use a chair, hence the sit part. But then we also do some standing work and some balance, but it's just trying to get people moving, and it's fun. And yeah, I hope you'll join us. And then since it's virtual, if you know anyone else that you think would benefit from it, just let them know as well. The more the merrier. Okay, and then the last thing we'll talk about is, before our break, is pelvic floor issues. So oftentimes with breast cancer, women will have pelvic floor dysfunction because of lack of estrogen or going into menopause. Some issues that we can help with are tightness. So vaginal tightness, there's different ways we can help, like either manually, where like one of my coworkers will like put a glove on and kind of get in there and help stretch things out. There's different, almost like exercise equipment, that's sort of a funny term, but there's different sort of tools that you can use too to help stretch out. There's incontinence that can happen for lots of reasons, but and there's lots of different types of incontinence. There's the I pee a little when I sneeze, or jump, or laugh, or the I go from not really having to pee to, oh my goodness, if I don't get to a bathroom now, I'm going to wet myself. Like there's all different types, and PTs are fantastic at helping you strategizing through all of those. With incontinence, there's definitely exercise and posture are parts of that, but there's also different like lifestyle modifications your PT will talk you through, such as like how many liquids, how much, the quantity of liquids you consume during a day and what time during the day. Sometimes, believe it or not, people who are incontinent, an issue is not drinking enough, when, you know, you're thinking, I don't want to drink more because then I'm going to have to leak, you know, or whatever. But so PTs can talk you through all those sorts of things. Okay, so, oh, and then pain. Oh, sorry. So pain with intercourse, or even just pain in general, is something that PTs can help with. And there's lots of different strategies for that. And then dryness, sort of, and I put sort of because really what would best help with dryness would be estrogen, but that's, you know, for a lot of women, that's not an option. I know some of the oncologists say like suppositories or like creams, estrogen creams are okay, because it's, you know, so that's a conversation for your oncologist. But where we can help as PTs, we know lots of different lubes on the market. So we can, you know, and some of them, like if you have pain, this is a good one. If you are allergic to this is a good one. Like there's lots of actual, the pH, whoever thought of the pH of a lubricant, but we do. So like there's different things that we can share with you about that. Yeah, so we can kind of help with that. Okay. So now, before we get into lymphedema, we're going to do a few minute, just open floor, like any questions. Everyone doing okay? Yeah, good.
I wanted to add into the pelvic floor. We also will be having another webinar this Thursday. Yeah, our director of pelvic health is presenting on incontinence and how physical therapy can help. So if you guys are interested at all in that, we're also holding one. It's this Thursday at 3 p.m. on Zoom to 4. And then I wanted to add in another thing as well. At Rehab Specialist, if you guys are looking to come into the office or have any questions about coming in, we take most insurances. So what I'll do is I'll also post that sign-in sheet at the end, towards the end. So put in your info there and let us know if you're interested. We can definitely reach out to you and help you scheduled if you have any questions at all.
Sure. And then something I'm going to add to Sabrina's addition, pelvic thing, May is teaching that. She's amazing, and she also works with breast cancer, so she knows a lot about the particular challenges with the pelvic floor and breast cancer. And if you have questions, like more questions, or you want to do a one-on-one, I'm also doing telehealth. And if you're not quite excited about going into the clinic yet, we're doing everything like to the top notch, but I under, you know, as far as safety, but it's crazy times out there. So we could also do a telehealth where you and I could speak and bill your insurance through it, so you don't have to pay for it. So, okay, this because we're kind of running long, I'm going to go right into lymphedema. All right, so usually I ask you guys what you know about lymphedema. Does anyone want to share anything, what they know or anything? Or let's just make that a rhetorical question. So just kind of think in your head what you know. And let's start with, what is the lymphatic system? So basically, it clears the junk from our body, and it does this using freeways to move the fluid. So here are the freeways, and here are the freeways in real life, and then here they are, what we're talking about in our body. Like, so if I had like fluid in my foot, I would use these freeways, and eventually it ends up, it ends up getting dumped into our veins, the dirty lymph fluid. So just a quick anatomy thing. Our blood, like the fresh blood, the arteries take the fresh blood out, they go around, they oxygenate, do all the good stuff, and then the veins bring back the unoxygenated, kind of like, we'll say, the dirty blood. And so the lymph gets dumped in with the dirty blood, and then it gets cleaned through filtered through the kidneys and all that sort of stuff. Okay, so along the freeways, though, are toll booths, and those are the nodes. So the nodes are in specific places of the body, so they're not everywhere. There's some in the armpit, obviously, and there's a lot in the groin. Other places, when we talk about like, oh, my glands are swollen, I'm getting sick, those are actually lymph nodes. And what the lymph nodes do is they check the lymph fluid for anything suspicious. So I kind of actually think of them more like border security, where, the fluids are going through and they're just kind of like, everything cool, any arms dealing or drugs in that car? No, cool. So in our body, what happens is as the fluid goes through, they're checking to see if anything weird is happening. If they say they find a bacteria or a virus, then that alerts the rest of the body, like, oh, okay, we got something going on here. So that's why, for example, when we say our glands are swollen in our neck, if a bacteria or a virus or something came in through our mouth or nose, it ends up in the fluid and gets trapped in here, gets filtered through here, and then they kind of can puff up when they're really active and like alerting our immune system to kind of rev up and get going. So with cancer treatment, that can disrupt this whole system in two major ways. And those ways are removing the lymph nodes, so typically from the armpit, and radiation can also damage them. So when the cars back up, like in that last picture of the traffic, that's the lymph fluid backing up, and that's lymphedema. The next slide has pictures of lymphedema, but it's the extreme version. So this is someone that, for whatever reason, wasn't able to get treatment for probably years. So I just want to set you up for that, because it's can be kind of startling to see. But why is lymphedema bad? So aside from how it looks, the skin can change, and it can get thicker, develop a bumpy texture, even change colors. And when your skin changes like that, it's not as robust as it once was. And it's much easier to get infections, and sometimes infections can end up in hospitalizations, or, you know, they can be nasty. And then if you have this poor person, you know, if your limb is that swollen, it can be hard to move them. Okay, so how do I prevent lymphedema? And the harsh reality is that you actually can't 100% prevent it. There are, however, things that you can do to minimize your risk. And let's talk about then, what is the risk? So there are 4 main risk factors, and these are the 4 that that science and research can back up. Like, there's data behind these 4 factors. There are other factors that you may have heard, like flying on an airplane, or like there's other things you may have heard that either are kind of older ideas about lymphedema, but these are the 4 main ones, so we'll just stick with that. And those are radiation, how many nodes you have removed, if you had a history of infection, and obesity. I mentioned this earlier about exercise, so your BMI, if it's greater than 30, that's considered a risk factor. And if you're like, I don't know what my BMI is, if you just type in a Google search BMI calculator, it'll pop right up and it'll give you your numbers here. So we're going to go through each of them. The first one is infection. So we want to try to do good skincare. Blech. Do good skincare. Excuse me, I'm starting to talk fast again. If you've ever heard another kind of older lymphedema precaution or restriction was never get a manicure or a pedicure. And that's only because if we've all seen that 2020 special or Dateline special about the uncleanly manicure place where the people don't clean things and they all get staph infections, that's why this is on the list, because we don't want you to get an infection. So if you are going to get a manicure, make sure it's your own tools. If you know, even better, have them leave your cuticles alone, because that's usually, if anything's going to happen, that's where, like, mine are terrible, and I always get a little nick in mine, and that's just like an opening for an infection. Pets, like, you know, cats can scratch you. If you like to garden, just be careful about thorns or anything like that. And then if you do get a cut, just clean it immediately and cover it with a Band-Aid, and just, you know, you can go on with your life. Like, it shouldn't really be a big issue, versus like, oh, I have a hangnail, I pull it, it's fine, and then I go on with my day. Like, instead, just get up, wash your hand in the sink. Like, just be a little bit more fastidious about it than you might typically be. And to be clear, that is for the side that had the nodes removed. So if my cancer was only on my left side and I get a hangnail on my right, it's not really a big concern. Same with pedicures. If you know, if I had breast cancer, pedicures aren't a concern. Okay, moving along. So obesity. So here is that, what you'll see, something like that if you type into Google, that, you know, the healthy range. And again, back for my soapbox before, ask for help. Join Sit and Fit. You know, if you need help beginning an exercise program, we are here to help you. Okay. How do I know if I have lymphedema? Here's some ways to check. One, kind of get in the habit of just checking your arms daily, you know, first, just to kind of get to know them. Like, one, to get to know them, and then once you know them, you'll notice a difference. And so the way I recommend is, like, one, like, kind of look at, like, the top of your hands, like the knuckles. Like, okay, I see a few veins, I can see some tendons. Then I'm going to flip my hand over and look at my wrists, kind of get a sense of, like, do I have creases, that kind of thing. And then if I bend my elbows, like, kind of hands at my shoulder, and look at my elbows, you know, ideally I wouldn't have a jacket on, but if you just want it like this circumference, it should pretty much look the same. Sometimes lymphedema will sneakily begin right about, like, will kind of be in the elbow, and you'll really notice it if you bend your arms like that. Some women feel heaviness, and lymphedema is usually not painful. And I mention that because I've been approached by women too who are concerned, like, oh my goodness, I have this new pain in my arm. Is that lymphedema? From what we're told in school, that's not the first thing we think. Like, I never think, oh my gosh, their lymphedema is starting. More likely it could be cording that's starting or something else. They actually teach us in PT and lymphedema school that lymphedema is not painful. However, I have worked with enough women over the years who have told me that theirs is. So, you know, if it's, I guess maybe the takeaway is like, if you feel pain in your arm, the first thought shouldn't be lymphedema. Like, if anything, I think if you're someone who has lymphedema for years, it might be kind of an achy thing, but it's not typically like a really acute, new, awful, like sharp, sudden kind of pain. So you'll notice we just spoke only about skincare and BMI, because those are the 2 of the 4 risks. Again, being how many nodes, radiation, BMI, and skincare. Like, if you need the nodes out, you need the radiation, there's really nothing it is what it is. But skincare and weight are the things we have some sort of control over. Okay, so what happens if I get lymphedema? Don't panic. If you notice swelling, call your doctor. Come in and see a lymphedema therapist or a physical therapist. Actually, I'm going to stop for a second. So to be a lymphedema therapist, you need some sort of other degree first. So that's like either a physical therapist, occupational therapist, sometimes nurses, and then sometimes massage therapists do it too. So just kind of educate you guys on that. What's great about if you find, I am more of an advocate for the like PT or OT or someone who has a medical degree to be your lymphedema therapist versus just like a massage therapist. We have massage therapists can be amazing, but I think it's nice to have someone with a medical degree kind of on your case, just in case there's something else going on. But what we do is, like, when you would come in, we would look at everything, get your medical history, look at your skin, range of motion, strength, all that. And then we measure the limb, and we compare the right side to the left side and see if there's any difference. There's a special massage to reroute the fluid. So if, for example, I had lymphedema in this arm and I have lymph nodes here that were taken out. So typically I would move fluid from here, like the fluid would drain there. But if I have lymph nodes taken out from here and this area isn't working, I actually would use my massage to bring it over to the other side where all the lymph nodes are. So there's a special massage to help reroute the fluid, and we would teach you how to do that. In some cases, we need to bandage the limb to make it smaller. And that bandaging kind of looks like ACE bandages. They're different, but they look the same. And we wrap up, we put this fluffy stuff, we might put foam. It kind of looks like you have one mummy arm. Like you can write, you can drive, but it's a little bit limiting to your motion, but that 100% works to get your limb smaller. That extra compression kind of takes the fluid that's been floating around and like kind of squishes it back down, and then it can get out of the limb. After that, you might need a compression garment, which is what this person's wearing right here. And we can help measure you for the correct size and compression. Okay, so I have a little gift for you guys, and that's diaphragmatic breathing. And that really is the single best lymphedema exercise or lymphedema prevention. It stimulates your entire lymphatic system. So just by doing deep breathing, that helps. It also can help, again, if you are constipated, like if any of the pain medicines or any medications you're giving kind of slows your digestion down. It's excellent for that. It's also really great for just kind of relaxing and managing stress or anxiety. So it's a really lovely thing to do at bedtime. And here's our little handout of how we do it. So when you inhale, you're going to let all of the tension out of your tummy. So your tummy will naturally kind of fill up. And then when you exhale, the tummy just gently comes in and you breathe out through your mouth. So inhaling, tummy expands. Exhale, it relaxes. There are so many different like YouTube videos or things, like if you want, or ask us if you want more more info on how to do the breathing, or if you've tried it and it's not working for you, I have lots and lots of hints on how to make that better. But to save time for questions, I think we're just about done. We already talked about motion is lotion. That's kind of like a PT, kind of like a corny thing we put on our PT t-shirts and things, but we talked about these earlier. Not only can it help reduce cancer risk, but diabetes, et cetera, et cetera. Conclusion, I hope you guys are concluding that YPT is an integral part of recovering from the breast cancer treatment itself. And now I would love to open for questions. So let's first do, if you guys don't mind submitting your questions recording, let's do those first. So if anyone has a question and doesn't mind being recorded, we'll do those first.
I just wanted to quickly clarify, you had said towards the beginning that when it came to scars and that the silicone creams, was it, that was distinctly helpful? What was it?
Yeah, there's tape that you can use.
Okay.
And there's two types of tape, one that is reusable and one that you would throw away each time. Personally, I would use the throwaway kind, although like typically I like to like reuse and be, you know, think of the planet, but I just worry about how can you, like if you take it off and put it down, I just worry about the cleanliness of it.
And can you get it in a drugstore? Is it over the counter?
Yeah, Amazon, yeah, you could get it over the counter. And they have them some with, if you are allergic to adhesives, they have a gel version too. But if you like start looking at the scar things, you'll see like there's lots of different, like my product's better. No, my expensive product's better, but it seemed through the research, it was really just the silicone that was the main important component.
Okay, perfect. Thank you.
Hi, I had a question. First of all, thank you so much for doing this. So helpful so far. I had a question. You mentioned that flying on an airplane, of course, which nobody's doing right now because of COVID, is not necessarily a risk factor for lymphedema. I've always heard that it is. So can you talk a little bit more about that?
Sure. And when I did my lymphedema training it was about 2005, I learned that as well then, that yes, because when you're on a plane, even though the cabin's pressurized, it might not be as pressurized, so you might swell. When they did, like 10 years later, when the National Lymphedema Network, they're kind of like the governing board of lymphedema in the United States. They credential the programs, that kind of a thing. They like set the standards. When they did a literature review of all the newer research, they couldn't really find that it did. That, you know, it wasn't definitely like, oh yes, most women who are at risk who go on an airplane and don't wear a sleeve get it. Like that just wasn't shown. There was actually some concern for not wearing, like if you are maybe a larger person in your, you know, planes are like this and we kind of are all squished like this, like could that be a bad thing to wear a sleeve? Like now am I cutting off my circulation in my elbow from wearing it? So it's now this kind of annoying gray area of talk to your lymphedema therapist. Like and so when I have discussions with women about this, the things we consider is, if you've ever had lymphedema prior to your flight, then 100% you want to wear the sleeve. If you haven't, let's go through your other risk factors. Like, are you kind of high risk to begin with? Do you have the personality that like it just feels better just to have it? Or are you someone like, oh my God, if I see it, it's just gonna make me more anxious? You know, like we just kind of like talk about those things. I think a really nice middle of the road is maybe be measured and have one. So if you're now in Cancun or wherever, and like, I think my arm is swollen, you can just put your sleeve on. Like that's oftentimes where I land with people, but those are kind of the different considerations. But you'll hear that from doctors and everyone, because I think it was like the one bulletin point that everyone got on lymphedema for all these years. So you'll definitely hear that. Thanks.
Thank you.
Yeah, great question. I'll also mention I have a Facebook group called My Breastie Says, BREASTIE, and I have a website too. I'm on Instagram and all that. So would love for you guys to join the group. It's I am just again trying to fill in the blanks on where the questions I hear in the clinic a lot that women aren't easily finding answers to, like all those sort of things, I try to just pass that along. And then it's a really lovely community, a lot of LA based. So also a great place like, hey, where did you guys get your nipples tattooed? Or, you know, like you can kind of like get different resources. So.
Can you put the name of the group in the chat? Just so you said
That's a great
breast IE.
That's a
Because I mean, having, I know at the very start of this, when you said that, you know, it's always nice to have met someone before they have their mastectomy. I mean, I'm just thinking through how helpful, like I didn't start doing my rehab until post-surgery. And so, you know, I mean, the patient often is we don't know what we don't know, you know, and so I'm really interested in,
oh my God,
you know,
I can't find the chat box. I feel like I'm 100 years old right now.
I think you have to just click the, I mean, well, in some cases, the more, and then chat option, if you click more.
Sabrina, are you still there?
Yeah, I can put it
for
down
me.
here.
MY
My breasty.
RESTIE says SAYS. Thank you. Oh, now I see the chat. Yeah. Okay. Awesome. Yeah, that's it on. So that's on Facebook and Instagram. Yeah.
Perfect. Thanks.
Yay.
So I know we're ending here, but I just wanted to thank everyone for joining in. We're so happy and so excited that you're all here to join. Like I said, if you had any questions about coming into the office, we take most insurances. Definitely put it into the sign-in sheet that I posted into our chat. But I don't know, Jenny, what do you think? Are you free for just a few minutes for private?
Even as private, I'm absolutely free and happy to talk to anyone anytime.
We also have the webinar this Thursday for our pelvic health. If you're also interested, let me know. Put it in the chat. I'll send you the link as well.
My email and chat.
Yeah.
It's Jenny at rehabspecialistinc.net. So it's, oh, hold on. Send to everyone. Okay, there we go. Yeah, so that's that. All right. So any private questions? Everyone okay? You can email me too, now that you have my email.
But yeah, thanks everyone for joining. We really, really appreciate it. We hope you enjoyed it.
Yay!
Thank you.
For sure. Thanks so much.
Thanks,
Yeah,
everyone.
Very
you very much.
worthwhile.
Oh,
Thank
good.
you.
No problem. Thank you.